This will enhance visualization of the vessels. And plus visualization of the vessels, he will enhance visualization of the tiny nodules. As you can see here, here you are worried or suspecting, are there true nodules or no? See, using the maximum intensity projection, they are obvious and they are miliary, randomly distributed. This is another example of nodules suspected here, using the maximum intensity projection, make them appear clearly. And of course, now you know that the pattern here is miliary, not perilymphatic, not centrilobular. Centrilobular nodules, which is the topic next time, and just talk about the introduction. The centrilobular nodules, and to understand why I split the nodular pattern into two, the centrilobular nodules are divided into three categories. We have ground glass nodules, we have soft tissue nodules, we have tree in bud. All are centrilobular in location, located at the center of the pulmonary lobule, so they are not reaching the major fissure or the pleural surface. They can branch into tree in bud appearance. So we have three groups. Each has different differential diagnosis. Here we have the ground glass nodules located at the center of the pulmonary lobule. If they are soft tissue density, they have different differential diagnosis here in the diagram showing the pulmonary lobules to show the location. According to this, they are almost evenly distant from each other. And they are far from the margin, either the fissure or the costal surface. And the third group, which is the tree in bud, also at the center of the pulmonary lobule, has different differential diagnosis, and it has characteristic group of disease called chronic suppurative airway disease. All this will be discussed next time. Okay, let me also explain here why some of the centrilobular nodules are ground glass, why the others are soft tissue, and why the third group is tree in bud. Here, the bronchus, if there is inflammation around the bronchiole, it will cause just inflammation in the adjacent perialveolar structures. So it will cause partial obscuration of the underlying structures, will not replace the whole air, so it will be gray in color. But in case of centrilobular nodule of soft tissue density, here there will be consolidation around the inflamed bronchus, causing soft tissue nodule because of the formation of the consolidation due to replacement of the air in the alveoli. But in the tree in bud, there will be impaction. Here will be impaction, so the impaction will continue into the branching of the terminal bronchiole, causing the tree in bud appearance. So here we have centrilobular nodules of ground glass nodules. The mechanism is peribronchiolar inflammation with partial air preservation. That's why it's gray in color. Gray in color, ground glass nodule. Soft tissue nodules, centrilobular in location, occurs because of peribronchial cellular filling. There is focal peribronchial consolidation with replacing the air, completely replacing the air. That's why they appear like consolidation, soft tissue density. The tree in bud, there is impaction of the terminal bronchioles, producing branching centrilobular soft tissue opacity. So you can say, in general, tree in bud is part of the centrilobular soft tissue nodules. So soft tissue nodules can appear solely without tree in bud and can appear also with tree in bud. So tree in bud is part of centrilobular nodules, soft tissue nodules. What about Can sensory lobar nodules, ground glass nodules, show tree in bud? Yes, one case, in one case only, which is the follicular bronchiolitis. Otherwise, if you see ground glass opacities, central lobar ground glass opacity or nodules, they are not branching. We're not showing tree in bud. There is one exception, is the follicular bronchiolitis, and these are the differentials for the central lobar ground glass nodules. See the list. We have airway bronchiolitis disease, which is the more common. See the list. We have 5 here. We have vascular causes, vascular disease, pulmonary edema, pulmonary hemorrhage, and pulmonary hypertension. And I will discuss the 5 groups of pulmonary hypertension under this topic. In causes of central lobar nodules, of soft tissue nodules, density. We have endobronchial spread of infection. We have endobronchial spread of tumor. We have aspiration-related bronchiolitis. These are the differential diagnosis. Tree in bud, it's a highly specific sign for infection. The common cause is infection, but there are uncommon causes like diffuse pan bronchiolitis, aspiration bronchiolitis. We will discuss all that in nodular pattern part 2. And thank you for today. And I appreciate your good listening, and see you next week. If someone have question, I am ready. I think you are exhausted, right? So see you next week. And if you remember anything to ask, I am available. You can send me your question. And thank you very much. See you next week. Thank you, Dr. Nokas. See you later.